Welcome to episode 15 of the APPNA Pediatrics Neonatal Perinatal Medicine Board Review. Domain 10, Water, Salt and Renal, carries 6% of the ABP exam. This episode covers insensible water loss and fluid management, sodium, potassium and calcium disorders, SIADH versus cerebral salt wasting, acute kidney injury with KDIGO staging, and renal anomalies, including posterior, urethral valves, and Potter sequence. Fluid and electrolyte management is tested heavily because small errors in premature infants have large consequences.
Insensible water loss is the primary driver of fluid management in the NICU, and it varies dramatically with gestational age. Extremely low birth weight infants below 1,000 grams lose 60 to over 100 milliliters per kilogram per day through transepidermal evaporation. Their skin is thin and poorly keratinized. Very low birth weight infants lose 30 to 60. Late preterm and term infants lose only 12 to 15. Factors that increase insensible water loss. Radiant warmers add 50 to 100%, phototherapy adds 20 to 30%, and fever. Factors that decrease it. Humidified incubators at 80 to 95% reduce insensible losses by 50 to 70%, and polyethylene wrap reduces transepidermal water loss in the delivery room. Board pearl. An extremely low birth weight infant on a radiant warmer without humidification can lose over 150 milliliters per kilogram per day through insensible losses alone. This drives the need for very high starting fluid rates in the most premature infants. Day 1 fluid requirements range from 60 to 80 milliliters per kilogram per day for term infants or extremely low birth weight infants in humidified incubators, up to 100 to 150 milliliters per kilogram per day for extremely low birth weight infants on radiant warmers. Advance by 10 to 20 milliliters per kilogram per day. The goal is 140 to 160 milliliters per kilogram per day by the end of the first week. Critical rule: hold sodium on day 1. Defer sodium supplementation to day 2 or 3. Hold potassium supplementation until urine output is confirmed. Expected weight loss in the first week. Term breastfed infants lose 5 to 7%, reaching the nadir at day 3 to 4, and regaining birth weight by day 10 to 14. Preterm infants lose 10 to 12%. Extremely low birth weight infants may lose 12 to 15%. 3 fluid phases to know. The oliguric phase from day 0 to 3, the diuretic phase from day 3 to 7, and the anabolic phase after day 7, where the target is 15 to 20 grams per kilogram per day weight gain. Board pearl. Weight loss exceeding 10% in a term breastfed infant warrants evaluation. The most common cause is inadequate breastfeeding, not pathology.
Hyponatremia, sodium below 135, divides into two types with opposite treatments. Dilutional hyponatremia, excess free water relative to sodium. The infant is euvolemic or hypovolemic. Treatment: fluid restriction. This is the mechanism in SIADH, depletional hyponatremia, true sodium loss exceeding intake. The infant is hypovolemic. Treatment: sodium replacement. This includes late hyponatremia of prematurity, occurring at weeks 2 to 6, caused by immature renal tubular sodium reabsorption. Treat with supplemental sodium at 3 to 5 milliequivalents per kilogram per day. Hyponatremia, sodium above 145, is most commonly from dehydration and excessive insensible water loss in premature infants. Treatment: correct slowly. The rate of sodium correction must not exceed 10 to 12 milliequivalents per liter per 24 hours. Faster correction causes cerebral edema from rapid water shifts into brain cells. Board pearl. Before treating hyponatremia, determine volume status. Dilutional gets fluid restriction. Depletional gets sodium. Getting this backwards is dangerous. SIADH versus cerebral salt wasting is one of the most tested distinctions in neonatal electrolytes. because they look similar on basic labs but have opposite treatments, both present with hyponatremia and concentrated urine with elevated urine sodium. The distinguishing factor is volume status, SIADH. The infant is euvolemic or mildly hypovolemic. Excess ADH causes water retention. Urine sodium is greater than 20 milliequivalents per liter. Treatment, fluid restriction, typically to 2/3 maintenance. Cerebral salt wasting. The infant is hypovolemic. Brain injury releases natriuretic, Ep3 times dailies, that cause renal sodium wasting. Urine sodium is very high, often above 80 milliequivalents per liter. Treatment. Aggressive sodium and fluid replacement. This is the opposite of SIADH. Getting this distinction wrong is dangerous. Fluid restricting a hypovolemic infant with cerebral salt wasting can cause cardiovascular collapse. Giving fluids to an infant with SIADH can worsen hyponatremia and cause seizures. Board pearl. Volume status is the key. If the infant is volume depleted, cerebral salt wasting. If euvolemic, SIADH. Non-Oliguric hyperkalemia of prematurity is a unique entity in extremely low birth weight infants below 28 weeks, occurring in the first 1 to 3 days of life. The potassium can reach 7 to 9 milliequivalents per liter despite normal urine output. This is what makes it non-oliguric and distinguishes it from renal failure-associated hyperkalemia. The mechanism is sodium-potassium ATPase immaturity. Potassium shifts out of cells into the extracellular space because the pump that maintains the intracellular-extracellular gradient is not fully functional. Management follows a specific escalation. First, calcium gluconate, 1 to 2 milliliters per kilogram intravenously. This stabilizes the cardiac membrane but does not lower potassium. Second, sodium bicarbonate, 1 to 2 milliequivalents per kilogram, shifts potassium intracellularly. Third, insulin, 0.1 units per kilogram with dextrose, the most effective potassium-lowering intervention. Fourth, albuterol or salbutamol nebulized. Fifth, furosemide for renal potassium excretion. Kayexalet should be used with extreme caution in neonates due to the risk of intestinal necrosis. Board pearl. Calcium gluconate stabilizes the heart but does not lower potassium. This is the most commonly tested misconception. Neonatal hypocalcemia divides into early and late with different causes and implications. Early hypocalcemia occurs in the first 72 hours. Causes: prematurity, immature parathiozoid response. Infants of diabetic mothers, maternal hyperglycemia causes fetal hyperinsulinism, which suppresses parathyroid hormone. Perinatal asphyxia and intrauterine growth restriction. Treat when ionized calcium falls below 1.0 millimoles per liter with symptoms, or below 0.8 regardless of symptoms. Calcium gluconate at 200 milligrams per kilogram per day intravenously, infused slowly with cardiac monitoring. Rapid calcium infusion causes bradycardia. Late hypocalcemia occurs after day 7. Causes: high phosphate formula intake. DiGeorge syndrome, 22, Q11.2 deletion, causing absent parathyroid glands, conotruncal cardiac defects, and T-cell immunodeficiency, and hypomagnesemia. The critical pearl, refractory hypercalcemia, that does not respond to calcium replacement. Check and correct magnesium first. Magnesium is required for parathyroid hormone secretion. Dose: magnesium sulfate, 25 to 50 milligrams per kilogram intravenously. Board pearl, late hypercalcemia plus cardiac defect plus recurrent infections equals DiGeorge syndrome. 22, Q11.2 deletion. Acute kidney injury in neonates uses the modified KDIGO staging system. Stage 1, serum creatinine rise of 0.3 milligrams per deciliter or more in 48 hours, or 1.5 to 1.9 times baseline. Urine output less than 0.5 milliliters per kilogram per hour for 6 to 12 hours. Stage 2, creatinine 2.0 to 2.9 times baseline. Urine output less than 0.5 for 12 hours or more. Stage 3, creatinine 3 or more times baseline, or creatinine 2.5 milligrams per deciliter or above, or need for renal replacement therapy. Urine output less than 0.3 for 24 hours, or anuria for 12 hours. Critical neonatal caveat. Serum creatinine in the first 48 to 72 hours reflects maternal creatinine, not the neonate's own renal function. It normally falls from 0.5 to 1.2 on day 1 to 0.2 to 0.4 by 1 month. A rise in creatinine after day 2 to 3 is always abnormal. Acute kidney injury occurs in 30 to 40% of NICU admissions and 18 to 30% of infants with hypoxic ischemic encephalopathy. Board Pearl, do not interpret a day 1 creatinine of 0.8 as neonatal renal failure. It is maternal creatinine. Wait for the expected fall.
The AKI differential divides into 3 categories with distinct management. Prerenal accounts for 60 to 70% of neonatal AKI. The kidneys are underperfused but structurally intact. Causes: hypovolemia, sepsis, cardiac failure, perinatal asphyxia. The hallmark: fractional excretion of sodium below 1% in term infants, or below 2.5% in preterm. Because preterm tubules have a baseline higher fractional excretion of sodium of 2 to 5%. Intrinsic AKI. The kidney itself is damaged. Acute tubular necrosis is the most common cause. Renal cortical necrosis has the worst prognosis. Nephrotoxic medications. Gentamicin is the most common nephrotoxin in the NICU. Extended interval once daily dosing reduces gentamicin nephrotoxicity. Postrenal AKI. Obstruction to urine flow. Posterior urethral valves. Bilateral ureteropelvic junction obstruction. Neurogenic bladder. Ultrasound shows bilateral hydronephrosis. A fluid challenge of 10 to 20 milliliters per kilogram of normal saline distinguishes prerenal from intrinsic. If urine output improves within 1 to 2 hours, it was prerenal. Board Pearl. Fractional excretion of sodium must be interpreted by gestational age. Less than 1% is prerenal in term, but you need less than 2.5% in preterm.
AKI management focuses on optimizing perfusion, avoiding further injury, and managing complications. Fluid challenge: 10 to 20 milliliters per kilogram of normal saline. Monitor urine output response within 1 to 2 hours. If no response, do not give additional boluses. Fluid overload exceeding 10% body weight increases mortality. Furosemide treats fluid overload but does not reverse AKI or improve glomerular filtration rate. This is a common misconception. Renal dose dopamine is not recommended. Avoid nephrotoxic medications. Adjust aminoglycoside dosing. Avoid indomethacin in the setting of AKI, and minimize iodinated contrast exposure. Renal replacement therapy indications: refractory fluid overload exceeding 15 to 20% of body weight. Potassium above 7 to 8, with ECG changes unresponsive to medical management. pH below 7.0 to 7.1, and blood urea nitrogen above 80 to 100 with uremic symptoms. In neonates, peritoneal dialysis is the preferred form of renal replacement therapy. It does not require vascular access and is hemodynamically gentle. Continuous renal replacement therapy requires a double lumen catheter and is reserved for larger infants or when peritoneal dialysis is contraindicated.
Posterior urethral valves are the most common cause of lower urinary tract obstruction in males. This is exclusively a male diagnosis. Incidence is approximately 1 in 5,000 to 8,000 males. Antenatal findings: the keyhole sign on ultrasound, a dilated posterior urethra connected to a distended bladder. Bilateral hydronephrosis. Oligohydramnios from decreased urine production. Postnatal presentation, dribbling urinary stream, palpably distended bladder, elevated serum creatinine, and bilateral hydronephrosis on ultrasound. Initial management, bladder decompression with a Foley catheter. Definitive diagnosis, voiding cystourethrogram. Definitive treatment, valve ablation via cystoscopy or vesicostomy if the infant is too small for cystoscopy. Prognosis, 25 to 30% of posterior urethral valve patients develop chronic kidney disease or end-stage renal disease. Potter sequence results from bilateral non-functional kidneys, either bilateral renal agenesis or severe bilateral obstructive uropathy. The absent or severely reduced urine output causes severe oligohydramnios, leading to pulmonary hypoplasia, which is the lethal component, limb compression deformities, and Potter facies with flat nose, recessed chin, and low-set ears. Board Pearl. In Potter sequence, the infant dies from respiratory failure due to pulmonary hypoplasia, not from renal failure.
Antenatal hydronephrosis is the most common prenatally detected anomaly, found in 1 to 5% of pregnancies. The Society for Fetal Urology. Grading system. Grade 1 is renal pelvis dilation only. Grade 2 includes calyceal dilation. Grade 3 is renal pelvis and calyceal dilation with parenchymal thinning. Grade 4 adds cortical thinning. Ureteropelvic junction obstruction is the most common cause. Diagnosed with a MAG-3 diuretic renogram, a T-half greater than 20 minutes indicates obstruction. Vesicoureteral reflux is graded 1 to 5. Grades 1 and 2 resolve spontaneously in greater than 75% of cases. Grade 5 has less than 10% resolution and usually requires surgical intervention. Multicystic dysplastic kidney is a non-functioning kidney that typically involutes by age 2. It does not require routine nephrectomy. However, the contralateral kidney has vesicoureteral reflux in 20% of cases. Obtain a voiding cystorthrogram. Autosomal recessive polycystic kidney disease, PKHD, one gene on chromosome 6, presents in newborns with large echogenic kidneys and congenital hepatic fibrosis. Autosomal dominant polycystic kidney disease, PKD1 on chromosome 16, or PKD2 on chromosome 4, typically presents in adults. Board Pearl. MCDK does not need nephrectomy, but does need a voiding cystorthrogram. 20% have contralateral reflux. Horseshoe kidney is fusion of the lower poles in 90% of cases, occurring in 1 in 400 to 600 births. The fused kidney is trapped below the inferior mesenteric artery and cannot ascend to its normal position. The key association is Turner syndrome. 20 to 30% of Turner syndrome patients have a horseshoe kidney. Complications: ureteropelvic junction. Obstruction is the most common complication. Wilms tumor risk is 2 to 8 times increased. Renal stones and urinary tract infections are also more common due to abnormal drainage. Other renal associations, to know for boards, unilateral renal agenesis occurs in 1 in 1,000 births. The remaining kidney undergoes compensatory hypertrophy. These patients need long-term monitoring for proteinuria and hypertension. Ectopic kidney, most commonly in the pelvis, has an increased risk of vesicoureteral reflux and obstruction due to abnormal urethral insertion. Board Pearl. Horseshoe kidney equals Turner syndrome. Bilateral renal agenesis equals Potter sequence. Posterior urethral valves equals male only. Acid-base interpretation in neonates requires understanding the unique physiology. Normal neonatal blood gas, pH 7.25 to 7.35, slightly more acidotic than adults. PaCO2, 35 to 45 millimeters of mercury. Bicarbonate, 18 to 22 milliequivalents per liter. Renal tubular, acidosis type 2, proximal, is the most common form in neonates. It results from tubular immaturity with impaired bicarbonate reabsorption. It causes a normal anion gap metabolic acidosis with urine pH less than 5.5 when serum bicarbonate is below the reabsorptive threshold. It is typically transient in premature infants. High anion gap metabolic acidosis in the NICU. The most common cause is lactic acidosis from sepsis, necrotizing enterocolitis, or hypoxic ischemic encephalopathy. Also consider inborn errors of metabolism, organic acidemias, and mitochondrial disorders. Respiratory acidosis indicates hypoventilation or ventilator insufficiency. Respiratory alkalosis, usually iatrogenic from excessive ventilation. Remember that hypocapnia, below 25 millimeters of mercury, causes cerebral vasoconstriction and increases the risk of periventricular leukomalacia. Board pearl, normal anion gap, metabolic acidosis in a premature infant equals proximal RTA type 2, until proven otherwise.
Domain 10 water, salt, and renal key facts for your ABP exam. Insensible water loss. Extremely low birth weight infants lose 60 to 100 plus milliliters per kilogram per day. Humidified incubators reduce this by 50 to 70%. Fluids. Start 60 to 80 milliliters per kilogram per day in humidified incubators. Advance by 10 to 20 daily. Hold sodium on day 1. Hold potassium until urine output confirmed. SIADH versus cerebral salt wasting. Volume status is the key. SIADH is euvolemic, restrict fluids. Cerebral salt wasting is hypovolemic, replace sodium and fluids. Non-Oliguric hyperkalemia. Extremely low birth weight infants. Days 1 to 3, potassium 7 to 9 despite normal urine output. Calcium stabilizes the heart, but does not lower potassium. Refractory hypocalcemia. Always check and correct magnesium first. KDIGO staging. Day 1 to 2 creatinine reflects maternal levels. Do not overdiagnose AKI. Posterior urethral valves. Males only. Keyhole sign. 25 to 30% develop chronic kidney disease. Potter sequence. Pulmonary hypoplasia kills, not renal failure. Horseshoe kidney. T-Warnes syndrome association. This is a single episode domain. Domain 10 is now complete.